Good morning, everyone. Welcome to Pediatric Grand Rounds. Thank you for joining us in person in the Mill Mountain Conference Room or virtually. Today's speaker is Dr. Manish Kumar, one of our third-year, soon-to-be graduating pediatric residents. After completing his medical school and pediatric residency in India, he came to the U.S. to pursue a child neurology residency, followed by a fellowship in neuromuscular medicine at the University of Virginia. He joined Carilion Children's Hospital as a pediatric resident 3 years ago. He has successfully passed the ABP and child neurology boards and is looking for a job as a pediatric neurologist. During his time, he was able to publish 14 articles in peer-reviewed journals and books, including 4 original articles, a few case reports, and a couple of book chapters. In addition, he has given us the gift of his lovely wife as a second-year pediatric resident. Please join me in welcoming Dr. Manish Kumar.
Thank you, Dr. Kumar. Good morning, everyone. It is my pleasure to talk to you about dystrophinopathies today. So this is a portrait of Guillaume Benjamin Amand Duchenne, the man behind our talk today. I have no disclosures. My objectives are to review the pathophysiology and genetics of DMD, which have implications for treatments, and to review the clinical presentation and natural history of Duchenne muscular dystrophy. I will also explore various diagnostic methods and testing strategies, and I will review finally the symptomatic and specific therapies for patients with DMD, with special emphasis on recent advances. Dystrophinopathies are X-linked recessive diseases that are related to dystrophin deficiency. They encompass the spectrum of disorders that include Duchenne and Becker muscular dystrophies, as well as the intermediate phenotype and DMD-associated dilated cardiomyopathy. DMD is the gene here. The gene's name is also DMD, and that's why it is put in italics. As well as muscle cramps with myoglobinuria, sometimes asymptomatic elevation of muscle enzymes, also called asymptomatic hypercikaemia, and manifesting carriers of DMD and BMD. Duchenne's first description of this entity was published in 1861 when he called it hypertrophic paraplegia of infancy due to cerebral cause. This highlights many of the characteristic manifestations of this disease, like enlargement of some of the muscles, and paraplegia, which is the predominant weakness or disproportionate weakness of legs compared to the arms. However, within 7 years of this publication, he was able to recognize that it was muscular in origin and not cerebral, and he was the first one to propose criteria for diagnosis. However, John Little, the man on the top, and Edward Marion, the lower one, they had reported this entity 8 to 9 years earlier than Duchenne did. A more benign form of X-linked muscular dystrophy was first proposed in 1955 by Becker and Keener, and then by Walton, and this was named Becker muscular dystrophy. The gene responsible for this condition was mapped to XP21 in early 1980s, and around 1988, complete complementary DNA of the DMD gene was sequenced, and the protein product was named dystrophin. DMD is the largest gene in humans. It has 79 exons. However, the exons constitute only 0.6% of the gene. That means more than 99% of the gene are introns. This spans over 1% of the entire X chromosome, so pretty large. And dystrophin protein is localized to the cytoplasmic side of the plasma membrane of muscle fibers. It has 4 functional domains that I'll come to it in a minute. And dystrophin is part of a large glycoprotein complex containing other proteins. They are called together dystrophin-associated protein complex. This is a diagram demonstrating the DAPC. So as you can see, this the large protein is dystrophin, which has 4 domains, as I was talking about. The amino terminal domain, which is actin binding domain, the rod domain, which is the largest one, and the cysteine rich domain, the smallest, but it is the one which anchors to beta dystroglycan, and that connects to the extracellular matrix or the basal lamina and binds to laminin alpha 2. And then the carboxy terminal, which has association with other proteins like syntrophins and dystrobrevins. So these are together, including the sarcoglycan complex, they are together called dystrophin-associated protein complex. And it is important to know these domains for the purpose of development of new treatments. Majority of the DMD gene mutations are deletions, and some of them are duplications as well, and the rest of them are point mutations. Point mutations include like frame shift mutations and small intragenic deletion insertion, missense mutation, nonsense mutations. And they are much more common in Duchenne muscular dystrophy compared to Becker muscular dystrophy. And majority of these deletions and duplications are clustered in two recombination regions. They are called hotspots, and more than 50% of them are located in between 45 to 55 and 3 to 9 exons. The severity of the disease that can lead to whether the severe form, which is Duchenne muscular dystrophy, and the milder form called Becker muscular dystrophy, can be inferred by whether the reading frame, the translational reading frame, is disrupted or preserved. For example, this deletion is disrupting the reading frame because, as you can see, the reading frame, after deletion of this exon or this part of the genome, the reading frame has inserted TGA codon, which is the stop codon, so there is premature termination of the dystrophin formation. Whereas in the other side, this deletion, even though it is large, it does not disrupt the reading frame, so the dystrophin can be formed, although truncated, but partially functional dystrophin is formed. So whenever there is out-of-frame deletion, it usually causes severe form, that is Duchenne muscular dystrophy, and with in-frame mutations will cause Becker muscular dystrophy. This also highlights the fact that even a small deletion can lead to severe isoform, whereas the larger deletion can still be possible to form Becker muscular dystrophy like milder variant. However, exceptions to this rule occur in 8% of cases. The dystrophin protein, it has many isoforms, and the one which is present in muscle, heart, and brain, that is the 427 kilodalton dystrophin protein. And if this protein is normal in size and amount, the diagnosis of dystrophinopathies can be excluded. In 99% of cases of Duchenne muscular dystrophy, they have complete or almost complete absence of dystrophin, and the amount is reduced to 0 to 5%. Whereas in Becker muscular dystrophy, the amount is reduced to 20 to 50%, but this reduction in amount accounts for only 15% of BMD cases, whereas in the majority, the 85% of cases have abnormal size. So the size can be either smaller, like what happens in 80%, and larger because of duplication in 5% of cases. And if the amount is between 5% and 20%, they may have the intermediate phenotype, which are called outliers. The pathogenesis of dystrophinopathies is multifactorial because dystrophin is the structural basis for mechanical stabilization of sarcolemma. Sarcolemma is the plasma membrane for the muscle. The central role in pathogenesis is of contraction into sarcolemma rupture. So when dystrophin is not there, when the muscle is contracting, it can lead to sarcolemmal rupture and muscle damage or myonecrosis. There are various factors that can tell about the extent of this damage, and that depends on size, maturity, and activity of the muscles. The other important factors that can contribute to the pathogenesis include loss of muscle nNOS, which is the neuronal nitric oxide synthase, which is the enzyme associated with dystrophin protein. And whenever the muscle is contracting, there is focal increase in the perfusion of muscle, and that is caused by vasodilation, and that is in turn caused by this nitric oxide synthase. So if the nitric oxide synthase is lost, actually it's delocalized to the cytoplasm. So whenever muscle is contracting, there is no increase in the focal perfusion, and that can lead to functional ischemia and exercise-induced muscle fatigue or damage. Now this delocalized nitric oxide synthase can actually form nitrogen species within the cell, within the muscle cells, and also reactive oxygen species are formed by NADPH oxidase type 2. So there is free radical damage as well, and glutathione levels are also reduced in dystrophinopathies, so there is definitely component of free radical damage. And it has been noted that there is cytosolic calcium overloading. So there is a sarcoplasmic reticulum, which is the endoplasmic reticulum of muscle cell, that has a receptor called rhinodine receptor that leads the calcium to go out of the sarcoplasmic reticulum into the cell, which participates in the contraction. And once the contraction is done or muscle is relaxing, that calcium is taken up back by the sarcoplasmic reticulum through SERCA. SERCA is sarcoplasmic endoplasmic reticulum calcium ATPase channel. So in dystrophinopathies, this partly because of this nitric oxide synthase, there is nitrosylation of this rhinodine receptor, and it remains open. So calcium continues to go out into the cell from the sarcoplasmic reticulum, and there is downregulation of SERCA, which is normally involved in uptake of the calcium. So there is overload of calcium within the cell, and that can lead to mitochondrial dysfunction and triggering of degradative pathways. The incidence and prevalence of DMD are much higher than Becker muscular dystrophy. Duchenne is about 3 times more common than Becker. The survival has improved over time, and patients with DMD can survive up to live in their 40s. Previously it was 20s, and that is primarily because of the optimal care that have been developed over time. The median life expectancy was about 25 years for those who were born before 1970, and it has improved to around 40 years for those who were born after 1970, according to one study. That's primarily because of development of multidisciplinary approach to these patients and improvement in the cardiorespiratory disease. DMD in females is very rare, and they are limited to individuals who have Turner syndrome, translocation involving DMD, uniparental disomy, or skewed lionization. Now, coming to the clinical presentation, briefly, the Duchenne muscular dystrophy patients present with weakness with onset between 2 and 5 years of age. They have pseudo-hypertrophy that I will discuss in a minute, diminished IQ, cardiac involvement, and then they have rapid decline compared to other phenotypes and wheelchair confinement by 13 years of age, and natural history is that death happens within 15 to 30 years of age. The wheelchair confinement age was used to distinguish between the various types of these dystrophinopathies. Like if they were wheelchair bound before 13 years of age, they were classified as Duchenne, and if after 16, they were classified as Becker muscular dystrophy. And if that happens between 13 and 16 years of age, then they are classified as intermediate or outliers. However, this natural history has been changed by the advent of many new treatments. So other parameters are also taken into account to classify them. Now, we'll look into Duchenne muscular dystrophy's natural history in detail. So during early infancy, they are asymptomatic. They do have elevated serum CK, which has the implication for potential newborn screening. And histologic evidence is present on muscle biopsy, even at that time. During first 2 years of age, they may develop delayed gross motor milestones. And the mean age of walking is 18 months. Between 2 and 3 years of age, they have overt manifestation with weakness, which is more prominent in the legs compared to arms, and proximal weakness is more prominent than the distal weakness. And they have difficulty with running, jumping, standing up from a squatting position, and climbing stairs. They also manifest toe walking. Between 3 and 6 years of age, they develop waddling gait, exaggerated lumbar lordosis, and calf enlargement. This calf enlargement is initially because of true hypertrophy of the muscle, because muscle is trying to regenerate. However, later on, the muscle is replaced by fat and fibrotic tissue, so that is called pseudo-hypertrophy. So initially it is true hypertrophy, later on it is pseudo-hypertrophy. And not only calf, but some other muscles are also involved in this enlargement. The Gower sign is the classical one, and just to mention that I've seen many people writing Gowers as apostrophe S. Gowers was the name, the name included S in his last name, so it should be written like this rather than apostrophe S. So this demonstrates the classical Gower sign. When the patient is asked to get up from the supine position, they turn to put the face down to the floor, and then they spread their legs and then climb with the hands slowly over their legs to stand up. The second picture demonstrates butt first maneuver, but finally that evolves into the classical climbing up on their legs to standing position. And that this happens because of the hip extensor weakness. The gluteus maximus is one of the first muscles to get affected, and then quadriceps, which is the knee extensor. So hip extensor and knee extensor muscles are the first one to get affected, and that is the cause behind this Gower sign. This picture demonstrates these two patients have a calf enlargement. So the second patient also has Achilles contracture, leading to fixed plantar flexion of the feet. So as I said, not only calf, but other muscles also can be involved in this pseudo-hypertrophy, like deltoid muscle and infraspinatus are other characteristic muscles that can be involved. This leads to the sign called valley sign, or valley between two mounts, because there is enlargement of the deltoid muscle and infraspinatus muscles, and the muscles forming the posterior axillary fold are wasted or atrophied. So this leads to like a valley between two mounts. The neck flexor weakness must be assessed because this can distinguish Duchenne muscular dystrophy from other varieties. That is because Duchenne muscular dystrophy patients have neck flexor weakness even early on, whereas this neck flexor strength remains preserved until late in Becker and outliers. Now moving on, between 3 and 6 years of age, they have something called honeymoon phase, because there is evidence of transient improvement, and that happens because of the normal development outpaces the disease evolution. However, even at that stage, the patients lag behind their peers in motor function. So this is a misnomer basically. And then happens the relentless deterioration. Between 6 and 11 years of age, there is rapid decline in many of the functions, especially the motor functions. And 6-minute walk test. That is a timed test, and it can be done in the clinic if you have a long corridor, like about 25 meters. And it is commonly employed in research settings as well. So it was noticed that if the 6-minute walk test shows the distance moved was less than 350 meters, the outcome was bad. And also the age. If they were older than 7 or older, they had worsening within the next 1 year. So they had demonstrated 10 or more % of worsening within next 1 year. And majority of them develop contractures during this age, and wheelchair confinement happens before 13 years of age. So this is the diagram showing the 6-minute walk test. So if the distance covered was less than 350, they had rapid decline, especially if they were older than 7 years. Whereas patients who had higher 6-minute walk test and they were younger especially, they had either stabilization or improvement within the next 1 year. Once the ambulation is lost, they develop weakness of the upper extremities, they develop scoliosis and deterioration of pulmonary function. The deterioration in pulmonary function happens partly because of the weakness of respiratory muscles, but also because of increasing scoliosis that develop, leading to restrictive pulmonary disease. And between late teens and late 20s, the majority of patients die secondary to respiratory failure or infection, and cardiac failure secondary to progressive cardiomyopathy. The median survival is 24 years overall, but if you break down 19 years for those who are unventilated and 27 years for ventilated patients. And it is 30 years for patients with both spinal surgery and ventilation. Other organs are almost invariably involved in these patients, and highlighting the fact that they need multidisciplinary approach. So heart, the most prominent involvement of heart causes dilated cardiomyopathy. And 1/3 of the patients develop before 14 years of age, but all patients will have dilated cardiomyopathy after 18 years of age. However, the manifestation of symptoms may not be apparent because they don't move much. So you may not get symptoms. They also may have cardiac arrhythmias, especially atrial arrhythmias. Dystrophin is also present in brain, so it can lead to various manifestations, like IQ scores are usually lower from the normal population. They may have verbal and reading skills. It's interesting to note that some of the patients can present only with speech delay or cognitive delay. So we should keep our differentials wide in those patients and send a CK. Autism spectrum disorder is higher in these population. And sometimes, rarely, seizures can also occur, but that has been described very rarely. Smooth muscle involvement can happen, leading to intestinal pseudo-obstruction or acute gastroparesis, but that's also very rare. Skeleton involvement is very common. Osteoporosis happens almost in everybody. And if they have frequent fractures, that can contribute to early loss of ambulation. And once the ambulation is lost, progressive scoliosis develops and respiratory function can decline. Adverse anesthetic reactions have been noted. The bottom line is that we should not use inhalational anesthetics or succinylcholine in these patients. Now, coming to the diagnostic testing. So, for the screening, whenever we have suspicion for Duchenne or Becker muscular dystrophy, we should send CK. A serum CK can be highly elevated, up to 50 to 200 times upper limit of the normal, and they are also elevated in newborn period and infancy, and they peak at 2 to 3 years of age. However, interestingly, the CK level gradually declines, as you can see in this graph, by 20% per year. So if you are screening a patient who is 16-year-old, may have only mild elevation or moderate elevation of CK. That should not lead us away from the diagnosis at that point, if we know this natural course. And that mainly happens because of the loss of the dystrophic muscles. So there's decline in the CK. And as we know that CK has 3 isoforms, the MM, the muscle isoform, the brain isoform, and the cardiac isoforms. MM, we expect that it should be elevated, and it is elevated in majority of the patients, actually all the patients. However, when there is regeneration of muscle fibers, the CK reverts back to the fetal isoform, and that is MB. So MB isoenzyme can also be elevated even if there is no cardiac involvement. So we should keep that in mind as well. Other muscle enzymes can also be elevated, like aldolase, AST, ALT, and multiple other enzymes, including LDS, but they are neither specific nor sensitive, so they are not helpful in diagnosis. Sometimes we see only significant elevation of AST and ALT, and many of these patients have undergone liver biopsy to look for any liver disorder before they were found out to have Duchenne muscular dystrophy. Electromyography is rarely used in this condition because this is non-specific and shows only myopathic changes. It is only helpful when we have suspicion about myopathic versus neurogenic disorder, but usually it is not used. Now, muscle biopsy was used very frequently in the past, but the rate of use of muscle biopsy has declined because of advent of the genetic testing. However, muscle biopsy is still helpful when the genetic testing has not revealed the diagnosis, or when we need to find out whether there is treatment response, like we are treating with some specific drugs for Duchenne and want to see whether there is improvement in dystrophin protein, then we have to do the muscle biopsy. The first picture, this one, shows the normal muscle, and as you can see, they have polygonal appearance and eccentric nuclei without any degeneration or regeneration. This one is patient with, from the patient with Duchenne Muscular Dystrophy, shows loss of the polygonal structure, and this is another one with NADH stain, and this one was HNE stain. So here we can see many of the muscles with like central nuclei, and there is degeneration of the muscles leading to necrosis and inflammatory cell infiltrates, and we can also see some of the fibers which are regenerating, which have large nuclei with vesicular nucleoli. Something called opaque fibers are also seen very commonly, and they are hypercontracted fiber, and that happens because of excessive calcium overload within the muscle fibers, as I was discussing earlier. So characteristic findings are variation in the muscle fiber size, loss of the characteristic polygonal structures, internalization of the nuclei, degeneration, and regeneration, or the replacement with the fatty and fibrotic structures. When we do muscle biopsy, some of the institutes also perform electron microscopy. The first one is the electron microscopy of a normal muscle, whereas we can see the highly electron-dense structures in the dystrophic muscles. The non-necrotic fibers can also demonstrate something called delta lesions, which are seen only on electron microscopy. And that is not characteristic or pathognomonic of Duchenne, but can be seen in many of the muscular dystrophies. Now, dystrophin immunostaining is invariably performed with muscle biopsy, and it uses anti-dystrophin antibodies. So this is the normal muscle, where we see the antibodies are showing that the dystrophin is localized in the sarcolemma, or the plasma membrane, whereas in Duchenne, it's completely absent. So you don't see anything. And this is another anti-dystrophin antibody, so the color is different, but this is the normal. And here there is partial staining of the muscle with Becker muscular dystrophy patient. And this is showing mosaic pattern in carriers, where some of them are normal, some show complete absence here of the staining, and some are partial staining. So different spectrum of disorders can be inferred from dystrophin immunostaining as well. And then Western blot, immunoblot staining is done to find out the quantitative analysis, to do the quantitative analysis. Like in this first 3 patients, there is complete absence of the dystrophin, suggesting Duchenne. And then these number 4 to number 8 patients have reduced. The 17 is the normal, sorry. And compared to that, it is reduced in these patients, suggesting it's Becker. And this is significantly reduced but not absent in patient number 11 and 13, so that is outlier. Okay. Now, skeletal muscle imaging is increasingly used nowadays with ultrasonography and MRI, and they can be used to monitor the disease progression as well as the treatment response. Now, coming to the molecular genetic testing, which is now almost always performed, because many of the treatments require them to have certain type of mutations before the treatment is begun. So as we saw earlier, that deletion and duplications cause majority of the mutations. So deletion duplication analysis is performed first with MLPA, that detects only exonic mutations, but CMA, or chromosomal microarray, can also be used, which detect exon as well as the flanking introns, but that does not detect point mutations. So if we don't find any mutation with deletion duplication analysis, then we go for sequence analysis or mutation scanning. And sequence analysis can be done with Sanger sequencing, which is the standard, and PCR can be used in low resource settings. And mutation scanning is done with various techniques. So this diagram is showing MLPA. If the probe ratio is more than 1.3, it suggests duplication, and if it's less than 0.75, it suggests deletion. Here it's showing the deletion of exons 46 to 50. The CMA also shows loss or gain of the genomic material. Here it's showing the deletion, and here the duplication. And this is the Sanger sequencing, which is the reading the genome letter by letter. The lowermost is normal, and the middle one is showing the homozygous mutation, and the upper one is showing the heterozygous mutation. I won't go into details of that because of the time constraint. But the stepwise approach is, as I mentioned, first do deletion and duplication, and then if that is negative, go for small mutation analysis. If that is also negative, then muscle biopsy or other techniques can be used to confirm the diagnosis. Now coming to the newborn screening, where we are at that. So a newborn screening can be done by measuring the plasma CK levels, because CK is elevated even in newborn period from dried blood spot. And if CK is elevated, then testing for DMD mutations are done as per the previous approach. And 20% of patients will have false positive, and false negative rate is very, very low. So if they have Duchenne's, they don't have low CK or normal. They always have elevated CK. Benefits of screening include emerging, we know that the emerging therapies are more effective in early stage. So benefit of screening is definitely there over there. And prompt referral for genetic counseling can be done if we know the diagnosis. And early identification of the carrier status of the mother also helps with decreased risk of DMD recurrence, because by the time the patient presents with characteristic manifestations of Duchenne by 4 years of age, by the time the parents might have had 2 more children, and if unfortunate, they might have 3 kids with Duchenne now. So risk is 50%, as we know. And another important thing is that female carriers are at risk of developing cardiomyopathy. So they need to be, if we find them early, we can send them for screening. Now, however, the newborn screening is not in use routinely. There were 3 states who did pilot studies: New York, Massachusetts, and North Carolina. And they found good results, like they found several patients with DMD. However, it has not been approved by the universal screening program. And also none of the states has adopted newborn screening yet, but hopefully it will happen in future. The prenatal testing is also possible if DMD mutation is known in the family member or linkage has been established. So first, we should determine the fetal sex, and if boy, then DNA can be extracted for further evaluation. And when the causative DNA mutation is not known, in utero fetal muscle biopsy can be done, but that is definitely not a routine procedure. And pre-implantation genetic diagnosis is available for families in which the disease-causing mutation has been identified. So before we move on to the management, I have a question for you. So considering the random X chromosome inactivation, which is also called lyonization, what proportion of females carrying an X autosomal translocation with breakpoints within the DMD gene will manifest signs and symptoms of DMD or BMD? So they have 2 X chromosomes. One has translocation with the autosome, and autosome is translocating in such a way that the DMD gene is disrupted. So this has DMD mutation. Another X chromosome is normal. So we know that randomly there will be inactivation or lyonization of 50% of the X chromosomes. So what do you think the percentage of manifesting carriers will be in this case?
Another 50%.
That's what we think, like it should be 50%. However, it is 100%. That is because, interestingly, suppose the a normal X is inactivated, then the disease will be manifested in all the patients, right? If the abnormal X, which is translocated, is inactivated, the patient or the cells will not survive because it has translocation with autosome, so it will not let the patient or the cells survive. So they will die off. The cells will survive only if they have inactivation of the normal chromosome, X chromosome. But whatever they are left with is a mutated dystrophin. So they will present in 100% of cases. So translocation carriers always manifest. All right. Now we'll move on to management. There is no cure for DMD as we know, but their life can be made better by improving their quality of life, by multidisciplinary approach. And the key partners for multidisciplinary approach include physicians, and many of the physicians are involved, including pediatricians, developmental pediatricians, neurologists, cardiologists, pulmonologists, orthopedic surgeons, endocrinologists, and also nurses, physiotherapists, PT/OT speech, RT, dietitians, psychologists, and social workers. So it's a huge team, and that's because they need all of them. The disease stage has been classified into like pre-symptomatic, early ambulatory, late ambulatory, early and late non-ambulatory phases, and guidelines have been published what we have to monitor and how we are going to manage in each different stage of the stages of the disease. It's worth mentioning that the best care guidelines are most often not evidence-based because of lacking randomized controlled trials, but they are based on best available evidence. So respiratory care is very important, and assessment of respiratory function with, especially with forced vital capacity and cough peak flow should be done annually from diagnosis. And once a loss of ambulation occurs, the respiratory decline can happen faster, so we should do every 6 months at that time. Peak cough flow, normally it is above 360 to 400 liters per minute. So if it is less than 270, they may need mechanically assisted coughing, like cough assist device. If the vital capacity is decreasing below 50% or the MIP, the mean inspiratory pressure, maximum inspiratory pressure is declining below 60, they may need nocturnal assisted ventilation. If they have symptoms of nocturnal hypoventilation, sleep studies should be performed. And if the non-invasive ventilation use, most of the time we use BiPAP for these patients. So if the use is extending into the daytime also, and if they are using 24 hours a day, then we should discuss with the family about tracheostomy. And we should make sure the immunization schedule is up to date, especially with pneumococcal vaccine and flu shot. Cardiac care is also important. Assessment of the signs and symptoms of cardiac insufficiency and arrhythmias, EKG, echo, and nowadays MRI is also used in many institutes. Should be done at diagnosis and then every 2 years until age of 10, and after that annually. Prompt initiation of treatment should be done with ACE inhibitor or beta blocker with early signs of cardiac dysfunction. The studies have shown that prophylactic ACE inhibitors in patients at around 9 or 10 years of age delay the onset of cardiac symptoms and cardiomyopathy. So it is being routinely implied. So ACE inhibitors are started at around 9 years of age, even when they have no symptoms. And evaluation of surgical options for joint contractures should be discussed, and baseline spine X-ray should be done to detect vertebral fractures and scoliosis. Annual follow-up assessment is used. Once they are non-ambulant, you can do either annually or every 6 to 12 months based on how severe the disease is. And if they have vertebral compression fracture, that happens in many patients, bisphosphonates should be used. And whenever we are sending the patient for surgery like spinal fusion, we should discuss the perioperative risk that can include acute rhabdomyolysis and adrenal crisis, because many of them are on steroid. So when we stop the steroid, adrenal crisis can happen. And increased risk of cardiorespiratory complications should also be discussed. Endocrinology need to evaluate the growth. Actually, everybody can do that. So assess for impaired growth, bone health, and glucose and fat metabolism and delayed puberty. All of these are already compromised in patients with Duchenne and further affected by glucocorticoids use. And dietary advice should be done, and diet should be adjusted based on the decline in physical activity and excessive appetite that can be associated with steroid use. So low-calorie diet once they become non-ambulant. And gastrointestinal management includes management of constipation and GERD that are frequent. And oropharyngeal weakness also can happen because we know that the upper third of the esophagus is skeletal muscle, which can be involved. So whenever there is risk of aspiration, or if they are not gaining weight, or if they are losing weight, we should discuss G2. And risk of gastric ulcer is there with steroids. So whenever the symptoms are noted, an acid blocker should be started. And growth and weight monitoring should be done every 6 months. Neuropsych evaluation is very important as well because of high incidence of cognitive impairment, ADHD, and autism spectrum disorder, anxiety, and OCD in these patients compared to the normal population. And early evaluation and timely interventions for speech development, learning, and behavioral issues should be done. Referral for neuropsych evaluation should be considered very early. And educational support will be driven by the results of neuropsych testing like IEP, and family support is at most important. Steroid treatment. So the steroids which are used for Duchenne muscular dystrophy include prednisone or prednisolone or deflazacort. These are the two, and they should be started in the plateau phase of the motor development. That means the patient is no longer gaining skills but not yet deteriorating. And that typically happens between 3 and 5 years of age. That is because if you start too early, steroids will have a lot of adverse effects that we want to avoid. And after the decline has already started, steroids may not be very effective. And the treatment is continued throughout life. That is because not only the muscle strength is improved with steroids, they also help with other functions. So when they are ambulatory, we focus on the leg strength, and when they become non-ambulatory, the upper limb function is also focused. So that is improved by steroid. Steroid also delay the ventilatory dependence, they delay the scoliosis, surgery, and cardiomyopathy. So many advantages of steroid, and that is why they are used throughout the life. Prednisone and deflazacort have not much of different side effect profile, but prednisone causes more weight gain compared to deflazacort, whereas deflazacort causes more cataract compared to steroid and compared to prednisone. The starting dose for prednisone is 0.75 milligram per kg per day, and deflazacort is 0.9 milligram per kg per day. The maximum for prednisone is 30, and deflazacort is 36 milligram. There are various other regimens that are used for prednisone use, like 10 days off, 10 days on, or only weekend regimen to avoid side effects, like only on Saturday, Sunday, high dose. But most of the patients are on daily steroid because the evidence for other on and off regimen is not very strong. If the patients are having, if they are tolerating the medication and they have still decline in motor function and dosage is below the effective levels, then we can increase the dose. If the side effects are unmanageable or intolerable, then we can do either of these. We can either leave the dose as same without increasing so that the patient gains weight and outgrows the dose of the steroid, or we can reduce the dose by 1/4 to 1/3. And we can consider changing the steroid like prednisone to deflazacort, or we can change the regimen, like daily to intermittent regimen. But however, even if after doing all these, the side effect remains unmanageable, then we need to discontinue the treatment. So now let's discuss about newer targeted treatments for Duchenne muscular dystrophy. There are 4 drugs that have been, these new drugs which have been approved by FDA, and that include eteplirsen, golodirsen, viltolarsen, and casimersen. Eteplirsen was the first one to be approved, and these are all antisense oligonucleotides that utilize exon skipping approach. So exon skipping means they bind to the exon in pre-mRNA and exclude that from splicing so that the out-of-frame mutation can become in-frame. So that is the idea. So restoration of the reading frame, and that leads to partially functional BMD-like, the Becker muscular dystrophy-like dystrophin is produced. So they have some dystrophin produced, not complete, but they still are functional, better than having nothing. This diagram depicts how it works. So suppose there is some mutation before, like exon 53, that is causing it to be out of frame from 53. So when the splicing happens, the protein will not be translated and it will be prematurely truncated. So the antisense oligonucleotide binds to the exon 53 here, and this exon is skipped during the splicing, so the 51 will bind to 54 directly, and the reading frame will be restored, and partially functional dystrophin will be produced. The ASO, or antisense oligonucleotide approach, is mutation specific, as we saw. However, as we already saw earlier, that most of the patients carry deletion in hotspots, so certain drugs can be beneficial for many of these patients. And it has been noted that exon 51 skipping can help 14% of patients. We should understand that this is not the exon which is deleted. The deleted or the mutated exons are around this exon, either before or after. So we need to skip this so that the reading frame is restored. So that happens in 14% of cases. Others, like 53 and 45, 44, are also involved in many of the patients. This shows the example of how different mutations can be targeted with one medication. Like golodirsen, which is 53 exon skipper, can help with all these patients who have different mutations that involve any mutation before 53 or after 53. And the orange highlighted ones are the more common deletions. Now the other approach is small molecules targeting nonsense mutations. Ataluren is orally bioavailable small molecule, so very attractive, and it induces ribosomal read-through of nonsense mutations. So just to let you know, all the AONs are injectables. However, Ataluren failed to achieve the 48-week primary endpoint of improved distance walked in the 6-minute walk test compared to placebo. However, all these trials had found a clear trend of therapeutic efficacy, and that led to conditional approval by EMA, or European Medicine Agency. However, it's not yet approved by FDA. Gentamicin is another one which reads through the nonsense mutation, but we know that it will have poor safety profile for long-term treatment, so cannot be used. So this is just showing the reading through the nonsense mutation leading to dystrophin production. Stem cell transplantation was an attractive approach. The rationale was that the transplanted cells will contain a functional copy of DMD and will contribute to muscle repair upon transplantation. It can be allogenic, if taken from other person, but that will require immunosuppression, and can be autologous, that will require correction of the gene prior to the transplantation. Stem cells that are used include satellite cells, which are the myoblasts, or the muscle stem cells, and other stem cells are also used for this purpose, which can convert to the muscle cells. However, the problems with this approach is, one is that myoblasts do not exit the blood vessels to go to the muscle. So if you deliver systemically, it's not going to be effective. You have to inject that into the muscles. Now, how many muscles we have? More than 700. How will we do that? It's very difficult. And even after we chose some superficial muscles, the dystrophin restoration happened only along the needle track. So it's not feasible for deep muscles especially. So it has not been approved and failed. Gene therapy is another attractive approach. And like you can add the gene if it's missing, or you can edit the gene if it is defective. So gene addition therapy uses the viral vectors to deliver a complementary DNA copy of functional DMD. Not many viruses have predilection for muscle cells or cardiac cells. So adeno-associated viruses do have predilection or natural tropism for skeletal muscles and heart, so they can be used. However, they are very small viruses, and they can carry only 4.7 kilobases of the material, whereas the complementary DNA itself of dystrophin is 11.4 kilobases, so very large. So very clever approach was that we can use microdystrophin using the only most crucial domains. As I talked to you about the 4 domains, the most crucial domains were taken from dystrophin and used for this approach. Another problem is that some patients may have pre-existing antibodies for AAV, adeno-associated viruses, so that can be handled by using immunosuppression before injecting this. And one other problem is that AAV does not integrate into genome. So it is possible that when the muscle cell turns over, the AAV will be lost. So retreatment will be required in those cases. But most of these patients will develop antibodies once we treat with AAV. So retreatment is very difficult with these. Gene editing therapy is like repairing the gene. CRISPR-Cas9 is used. That is so CRISPR is clustered regular. Yeah, I'm blanking on R, but it's cluster regularly interspersed small palindromic repeats. So they bind to the DNA, some of the exons of the DNA, and then it carries Cas9, which is the CRISPR-associated protein 9, and that cuts the DNA at that level, and then the DNA repairs by itself, leading to recombination, and there is a chance that the defect will be corrected by that. So that approach is under study, and it's very attractive as well. So this is showing the gene editing with CRISPR-Cas9. So CRISPR binds to, like same example, where it will bind to exon 53, and Cas9 will cut it, and then there will be like a recombination leading to correction of the mutation. So here we have to understand that it is different from antisense oligonucleotide, because antisense oligonucleotide binds to pre-mRNA, and CRISPR binds to the DNA itself. The other therapeutic approaches for DMD included in the past utrophin upregulation. The study is still going on, but many of them have not shown any effect, like isotromed. Utrophin is actually very similar to dystrophin, so it was an attractive approach. And utrophin is highly expressed in the fetal cells, and as the dystrophin level increases, the utrophin is downregulated. So if we are able to upregulate utrophin, that will function as dystrophin, many of the muscle manifestations can be corrected. However, the studies have not shown the same, still under development. Then myostatin inhibitors, like myostatin is a growth factor of the TGF transforming growth factor beta family that inhibit muscle growth. So if we are able to find some myostatin inhibitor that can help with the muscle growth, and soluble myostatin receptors like ACT2B have been used, but the trial was terminated because of high incidence of spontaneous bleeding. And myostatin antibodies were used, but they had no therapeutic effect. Similarly, adasalonexant was NF-kappa B inhibitor that was terminated due to lack of efficacy. So these are not very effective so far, but vamorolone is very attractive approach. It is an alternative steroid which has a better safety profile than prednisone and deflazacort. We know that most of the side effects of steroids like prednisone or deflazacort are caused by mineralocorticoid receptor activity. So vamorolone, interestingly, has mineralocorticoid antagonistic property. So it is under clinical trial, but once approved, it will be a breakthrough. Givinostat is also under study. It's a histone deacetylase inhibitor, and it improves regeneration and inflammation. It is under phase 3 clinical trial. So just to let you know that there are many treatments on the horizon that are being developed for Duchenne muscular dystrophy patients. So my second question is, which of the following treatment strategies for Duchenne can potentially restore full-length dystrophin protein? Exon skipping, like eteplirsen, viltorarsen, or small molecules targeting nonsense mutations such as atelurin, gene addition therapy with AAV vector, or gene editing therapy with CRISPR-Cas9. Somebody said C. D. So gene editing therapy also, like exon skipping, it cuts and then there is a recombination. So it will not be full length. It will be partially truncated, although functional. Gene addition therapy, as we saw, that we use only microdystrophin, and exon skipping definitely is the exon skipping, so it will not be full length. However, atelurin, which reads through the nonsense mutation, can produce full length protein, dystrophin protein. So in conclusion, dystrophinopathies are X-linked recessive diseases related to dystrophin deficiency, and Duchenne and Becker muscular dystrophies are the major ones. The different spectra of diseases can be explained by the reading frame rule for the most part, and it also has implication on the treatment, as we have seen. Patients present with delayed motor milestones before 2 years of age, and then difficulty climbing stairs, waddling gait, and frequent falls at 2 to 3 years of age. Most patients become wheelchair dependent at 10 to 12 years of age and need assisted ventilation at around 20 years of age. Cardiomyopathy occurs in almost all individuals after 18 years of age, and heterozygous females are at increased risk of DCM. Corticosteroids not only improve muscle strength, but also delay ventilator dependence, dilated cardiomyopathy, and scoliosis. ACE inhibitors and beta blockers, with or without beta blockers, should be initiated by 10 years of age to delay DCM. And dystrophin restoration therapies are available for selected patient groups who have selected mutations. And most importantly, it is important to understand the therapeutic approaches for DMD do not restore muscle tissue and function that is lost. So it is very important to treat the patients as early as possible. And that's why I'm hoping that the newborn screening can be adopted by many of the states to help with these patients. These are my references. Questions?
You said atrial arrhythmias are more common than ventricular arrhythmias. Do you know what is the reason behind that?
No, I don't know the reason, but most of the studies found that atrial arrhythmia was much more common, but I don't know the explanation behind it. Yes?
Is gene therapy, is it eligible for all types of Duchenne's, or are there specific mutations?
Yeah, gene therapy can be, if possible to do it, yes, it will be useful for all types of Duchenne muscular dystrophy, as opposed to using the antisense oligonucleotide. However, that is, I'm talking about the gene editing therapy, but gene editing therapy may not be useful for all types of mutation because that will cut only the particular exon. But yes, gene addition should be useful for all types of Duchenne.
Can you do a muscle biopsy on any of their muscles, or do you have to visualize the hypertrophy prior to?
Yeah, so very good question. So muscle biopsy, if done, is used in muscles which have like 3 out of 5 strength, because if they are very weak, like 0 out of 5, they are just going to show only the fibrotic changes and fatty tissue changes, which will not be helpful. And if they are very strong, they may not be yet showing the manifestation. So ideal muscle to biopsy is which have about 3 out of 5 strength.
You usually do like vastus lateralis, is that?
Yes. So most commonly it is the vastus lateralis, which is one of the first muscles to be affected.
Thank you so much, Dr. Kumar.